Welcome back to NephroTube Online Nephrology Lectures. In this lecture, we will continue the discussion of hemodialysis book NephroTube Synopsis of Conventional Hemodialysis. Starting from this lecture, we will start the discussion of vascular access of patients on hemodialysis. Chapter 9, we are discussing the basics, creation, use, and the examination of both arteriovenous fistula and graft. In the next lecture, we'll discuss chapter 10. We will discuss the complications of fistula and the graft also. In the description of this video in YouTube, below the video, we will find some important links. The first link is a link to this same lecture, but in Arabic language, for those who like to watch the lecture in Arabic. We'll find also a link to the playlist of video lectures about this book. You will find the link for the English playlist and Arabic playlist. We'll find link to download this book for free. We'll find link to download the PDF of this lecture for free if you like to use it. You will find a link for my website, NephroTube, nephrotube.com, where you will find more lectures about nephrology than hemodialysis lectures. And finally, you will find a link to NephroTube social media accounts, the WhatsApp group, the Telegram channel, the Facebook group. You can join us to be always updated by the activities of NephroTube. And finally, it's better to subscribe to our channel and to make the notifications on from our channel, so you will be notified once we upload new lectures. This is my talk outline. I will start by the discussion of upper extremity AV fistula. Then we will cover upper extremity arteriovenous graft. Then we will compare AVF versus AV graft regarding which is better to use. Then we will talk about lower extremity AV graft and AV fistula. Here we are talking about upper extremity. Here we will talk about lower extremity AV fistula and the graft or hero graft. And finally, we'll discuss how to clinically monitor physical examination of fistula and graft. Starting by upper extremity arteriovenous fistula. What is the main idea of the arteriovenous fistula? In hemodialysis, we want to withdraw the blood from the patient to the hemodialysis machine, then to return this blood back to the patient. So we are using needles of large size in comparison to the formal used cannula. So to use these large needles, we need the veins to be dilated and to be with high pressure. So we have to connect the veins of the arm with the arteries to transmit the high pressure of the artery into the vein. We have two types of anastomosis. I will talk about this later in this lecture. But whatever the type of anastomosis, there is anastomosis between the artery and the vein, where the high pressure of the artery is transmitted to vein. This helps the venous segment wall to be thick and undergoes arterialization and dilatation. And this helps in dialysis to obtain blood from this venous segment through the dialysis needles. An important point here is about vessel preservation. It is important to preserve the veins of the upper limb of the CKD patients, especially stage 3 to 5 CKD patients. It is important to preserve their upper limb veins for fistula preparations. So regarding venipuncture, if you want to have a venipuncture from this patient, and this is very common in these patients, because they usually do a lot of investigations for anemia follow-up, iron follow-up, calcium, phosphorus, PTH, and so on. So venipuncture preferred not to be from the non-dominant arm. Please correct this in the book in page 115. There is the word not is missed from the sentence. So it is not to be preferred from the non-dominant arm. So in other words, it is preferred to be from the dominant arm. Because as I will mention later, usually the fistula is preferred to be done in the non-dominant arm, as I will mention later. So it is preferred to preserve the vessels of the non-dominant arm. In general, if you will take venipuncture from the dominant arm, or even if you took it from the non-dominant arm for any reason, for example, the veins of the dominant arm are not large enough to take venipuncture, so it is better to use the most distal small veins. And if you are in need to take venipuncture from large veins, if the distal small veins are not sufficient, so it's better that highly experienced individuals should operate on them. The second point for vessel preservation is that it's better to avoid the use of central venous catheters for dialysis. That's why early referral of CKD patients for AVF creation or even graft creation is important and mandatory to save the central vessels of the patient healthy, and this will help for the AVF creation and maturation. Okay, when should AV fistula be created? When the GFR of the patient is less than 30, you have to start educating your patient about all the available kidney replacement therapy, as hemodialysis, peritoneal dialysis, and transplantation. And according to KDIGO, CKD guidelines 2024, when the GFR of the patient is less than 15 to 20, or if there is a risk of kidney replacement therapy more than 40% over 2 years, the patient must have his vascular access created. Okay, how to calculate the risk of kidney replacement therapy? The KDIGO mentioned two risk scores: the kidney failure risk equation, one with 4 variables and one with 8 variables. The one with 8 variables is more accurate, and I put the links for these calculators in the book. For example, this is the 4 variable calculator: sex, age, eGFR. Here I put data for one patient, urine albumin creatinine ratio, patient location, and this calculator will give you the risk of kidney replacement therapy over 2 years and over 5 years. For example, this patient, the risk over 2 years is 2.14%, and over 5 years it is 8.04%. If the risk score over 2 years is more than 40%, you have to refer your patient for vascular access creation. The last point, there is an opinion also that you have to make early referral of your patient for fistula creation if there is a rapid decline of GFR more than 10 milli per minute per year. Okay, about AVF preoperative evaluation. What is the preoperative evaluation that should I do for my patient before going for AVF surgery? For good assessment for our patient and the evaluation for our patient. First, we will start by history, then physical examination, then imaging. Regarding history, you have to ask your patient about any previous vascular intervention or surgery, as for example, insertion of pacemaker, cardiovascular implantable electronic device, previous catheter central line insertion, or any previous vascular surgery. Second, you have to ask your patient in the history about comorbidities as diabetes, congestive heart failure, any vascular disease, and you have to ask about history of previous failed AV fistula, and also what is the cause of failure if it is known. This is regarding the history items. Regarding preoperative examination, you have to examine all pulses of the upper limb, and you have to measure the blood pressure of the patient. And we know that there may be a difference in the blood pressure between the two upper limbs, but it is accepted to be less than 20 millimeter mercury. If the difference in pressure between two arms is greater than 20 millimeter mercury, so this indicates that there is a problem in the vascular access in the vessels of this patient, and we have to do imaging, as I will mention later. Then you have to do what is called the Allen test. Allen test is important to test palmar arch patency. This test will measure the collateral flow between radial and ulnar arteries at the palmar arch. How this test is done? First, you have to occlude both the radial and ulnar arteries in the rest of the patient. Then ask the patient to firmly compress his fingers. Then you will find his hand is blanched, his palm is blanched. Then you have to release one of the arteries. For example, here we released the radial artery. And check how his hand blanching will disappear and the vascularity of the hand regains. It should be regained in less than 5 seconds. If it persists blanched more than 5 seconds after the release of the radial artery, it is a positive sign of insufficiency of this palmar arch. You have to do these steps for the radial artery and then again for the ulnar artery. Here we released the radial artery, so you have to repeat all the other steps, all the steps again, then release the ulnar artery to check its collaterals. This test is important to be sure that if you used one of these arteries, radial or ulnar, in the fistula, that the other artery is sufficient alone to give perfusion for the hand. This is a test on a real patient. Here the hand is blanched, and with the release of one of the vessels, the blanching disappears and the hand regains its vascularity. Again, in the examination, you have to examine for any evidence of heart failure, as we will mention later in the vascular access catheter lectures, the central venous catheter lecture, that if the ejection fraction is less than 15%, so the fistula shouldn't be done. And also, because if there is heart failure, low cardiac output because of heart failure may cause immaturation of the AVF and the maturation failure. Also, as we will mention later, that creation of the fistula will cause high rapid hyperdynamic circulation. So if there is heart failure, the heart will not be able to tolerate this increased cardiac output. Then you have to examine the neck, chest, and the upper limbs of the patient for any sign of previous surgery, previous catheter, previous central line insertion, and also for any sign of central venous stenosis. And I will talk about central venous stenosis in details in chapter 12, and also we will talk about it at the end of this lecture. Then you have to check if there is evidence of infection in your patient. The Kiduki Vascular Access Guideline 2019 mentioned that if there is any evidence of infection, especially chronic infection in these patients, you have to treat and manage this infection first, before proceeding with AV access creation. For example, if the patient has dental infection, osteomyelitis, or any other infection, you have to treat this infection first before the creation of AV access, because this source of infection may cause infection of the AV access itself. So the final point in the pre-operative evaluation, after we took the history from the patient and we examined the patient, is pre-operative imaging. Regarding pre-operative imaging, the first line of imaging that is common to be done is Doppler ultrasonography. For Doppler ultrasonography, we comment on two important points: the vein size and the artery size and the mapping of the vessels. The minimal human diameter accepted for the vein for AV creation, AVF creation, is 2.5 millimeter, and for the artery is 2 millimeter. However, the Kiduki 2019 update mentioned that there is no minimal diameter, and arteries and veins less than 2 millimeter in diameter should undergo careful evaluation for feasibility of AVF creation by the surgeon. But I think this is not a common practice. Also, the radiologist must comment by Doppler on the depth, continuity, and the absence of a stricture in the veins. The main limitation of the Doppler that Doppler is inadequate for visualization of central veins. Okay, that's why we can use other procedure of imaging if you want to visualize central veins. And here comes the rule of venography. Venography is used if there is a suspicion of central venous stenosis or any other central procedure, central vein procedure, as pacemaker placement, to assess central veins. One important point here: if you suspect that your patient has central venous stenosis and you need to make venography, then you will use contrast. And this patient is CKD stage 4, CKD stage maybe 3, and the patient didn't reach yet to hemodialysis. So you are feared that the use of this contrast for evaluation of the veins may precipitate more deterioration of the kidney function, and the patient may reach dialysis. So it is recommended to use in these patients the smallest volume of iodinated contrast material, or use non-iodinated contrast agent as carbon dioxide venography, and this is commonly used nowadays. Finally, arteriography. Arteriography is indicated if the pulses in the upper limb are diminished, or when there is a difference in the arterial pressure between the two limbs more than 20 millimeter mercury, as we mentioned before. Again, you have to use the smallest volume of iodinated contrast material, or use non-iodinated contrast agent as carbon dioxide angiography. After we mentioned perioperative evaluation of the patient, now what are the AVF types and the possible locations? There are three types of AV fistula: conventional, transposed, and translocational fistula. The conventional AV fistula, it is just a creation of anastomosis between superficial artery and superficial vein. Very straightforward. Transposed, more complicated than conventional, where there is a deep vein. It is not a superficial vein as in conventional AVF. There is a deep vein that must be moved into a subcutaneous tunnel and anastomosed with an artery. And this type of AVF usually is done in two-stage surgery. Finally, vein translocation AVF, where this is more complicated than transposed, where a vein is surgically extracted from its anatomical site, for example, saphenous vein, and this vein is used to make a connection between an artery and another vein in the arm. So it is a complicated one. What are the possible locations of AVF? First, it must be done in the non-dominant arm, as we mentioned. These are the general rules for the choice of the location of AV fistula. Why we have to do it in the non-dominant arm? Because the dominant arm is usually utilized by the patient during his life. So there is high risk of trauma and injury to his dominant arm. But if the non-dominant arm vessels are not healthy for AVF creation, so you can make the fistula in the dominant arm. Again, you have to start the creation of the fistula in the distal vessels of the upper limb. And if distal vessels are not healthy for AVF creation, you can go proximally. Regarding the location, there are a lot of locations for creation of a fistula. And I mentioned them in my book, but I will comment now on the most commonly created AV fistula. The first one is rest radiocephalic AV fistula. This is usually the first choice, followed by arm brachiocephalic fistula, and finally transposed brachiobasilic fistula. As I mentioned, you have to start distally, and if vessels here are not healthy, you have to go proximally. You have to start distally to save vessels and make more opportunities for the patient to create fistula. For example, if in this patient you have started by creating an arm brachiocephalic fistula. If this fistula failed after some time due to any reason, now you have only one option, which is transposed brachiocephalic fistula. You cannot make radiocephalic fistula because you already did the brachiocephalic before it. But if you started with radiocephalic fistula in your patient and it failed for any reason, so you have two other options now and more options for the creation of the fistula. What about the techniques of anastomosis? We have two types of anastomosis. The first is side-to-side anastomosis, and the final one, the second one, is side-to-end, the side of the artery to the end of the vein, where the vein is ligated distally here and connected by its end to the side of the artery. The side-to-side anastomosis has a common complication, which is hand edema and discomfort. There is high risk of venous hypertension in this case, and causing hand edema and discomfort, which is called red hand syndrome. Radiocephalic fistula can be done as side-to-side or side-to-end, but brachiocephalic fistula is usually done in the form of side-to-side anastomosis. Is there an evidence that one of these techniques is better than the others? The answer is no, and that was mentioned by the European Renal Practice Guidelines 2019, that there is insufficient evidence to support one of these techniques over the other for the creation of AV fistula. Okay, one of the important points is the peri-operative prophylactic antibiotics. Should our patients take peri-operative prophylactic antibiotics for prevention of AV fistula infection? The European Renal Practice Guidelines 2019 commented on this point. They mentioned that you have to give perioperative antibiotic prophylaxis for complex AVF procedures. But for simple procedures, simple AVF procedures, as creation of native radiocephalic, native brachiocephalic, it is not recommended to give these patients prophylactic antibiotic. So you have to give in complex procedures. For example, the patient has deep vein, the patient has previous vascular access complications, whatever the situation. Regarding the creation of AV fistula, I will not talk about the surgical procedure itself, but I will comment on some points. It is usually done as surgical technique under regional block or local anesthesia. Nowadays, endovascular techniques are also available, and there is no enough evidence to recommend one technique over the other. It could be done by surgical technique or endovascular technique according to the experience of the center and there is no recommendation on the preferred use of surgical or endovascular technique for post-operative maturation. Let's go after the creation of the fistula through the post-operative instructions. Instruct your patient that his arm should be kept elevated. You have to educate your patient how to check the thrill daily, and if the patient can use a stethoscope, he can check the puree also. The patient should avoid compression of the fistula during sleeping or the use of tight circumferential dressing to avoid the compression of the fistula, and for sure avoid venipuncture from the fistula. An important point is the recommendations of Kiduki 2019 regarding the post-operative period, and I will start about the comment on post-operative exercise. It is a common practice to ask the patient to make hand exercise after the AV fistula creation to help AVF maturation. But actually, as mentioned by Kiduki 2019, there is inadequate evidence that the use of upper extremity exercise facilitate AVF maturation. And they mention that if you insist to use the exercise technique to help AVF maturation, it should be whole arm exercise, not only finger exercise. This will facilitate more AVF maturation. They also commented on the use of adjuvant infrared therapy. Adjuvant infrared therapy on the AVF can help AVF primary patency and maturation. But they didn't recommend that this should be done for all patients. They mentioned that it should be done based on individual circumstances and availability. Also post-operative, the surgeon or the operator who did the fistula should examine the patient again within 2 weeks of creation of the fistula for early detection of any post-operative complications, and also within 4 to 6 weeks of creation to check signs of maturation that I will mention in the coming slide. So what are the signs of AVF maturation, which we are calling rule of sixes? Rule of sixes because each statement contains the number 6. What are the signs of AVF maturation? First, you have to know that maturation usually occurs within 4 to 6 weeks following surgery. Then the venous segment of the fistula should be less than 60 millimeter below the skin. It should be superficial to make its cannulation easily. The venous segment of the fistula should be 6 millimeter in diameter. This diameter is enough for the insertion of the dialysis needle. And the length of the venous segment should be minimum of 6 cm. This will help cannulation of the venous segment by a raw bladder technique that I will mention later. And finally, blood flow of the fistula should be 600 milli per minute. So these are the rule of 6 that indicates the maturation of AVF post-operative. Now, after the fistula is maturated, we will start its cannulation. I will talk about AVF first use, the first cannulation, the first time to cannulate the patient. What are the recommended rules in this patient? It is important to mention that premature cannulation can be associated with complications and fistula loss. And the longer the wait before use of the fistula, the better the fistula outcome. So what are the recommendations for AVF first cannulation? These recommendations were mentioned before by Kiduki Vascular Access Group, Work Group 2006, and they are still standard till now. 5 points we have to mention regarding the first cannulation of the fistula. First day of the week. it's better to cannulate the fistula in a day without dialysis. This helps to avoid any heparin-related complications. Heparin that is used for anticoagulation during the hemodialysis session itself. If trial of cannulation of a non-dialysis day is not possible, then trial cannulation, initial cannulation, should be done at midweek treatment. For example, if the patient is dialyzing on Saturday, Monday, and Wednesday, the cannulation should be avoided to be on Saturday. It's better to be on Monday. Because on Saturday, the patient is coming from a long vacation, and there is a possibility of volume overload and high blood chemistries and abnormal bleeding coagulation profile because of uremia. So it's better to avoid cannulation after long weekend interval, and it is better and preferred to cannulate the patient for first time in a midweek treatment. The second point that should be considered in first cannulation of the fistula is the use of wet needle technique. In wet needle technique, we have to attach a 10 ml syringe to the needle and fill this syringe with 8 ml of normal saline solution and prime the needle with the saline. Insert the needle into the vein, cannulate it, then unclamp the needle. You will find a flashback of blood from the fistula into the needle. When the blood is visible, aspirate only 10 to 5 ml of blood by the syringe. Then flush the needle again with normal saline solution and clamp. The syringe must flush and aspirate with ease. And while you are doing this, notice if there is any signs and monitor if there is any signs or symptoms of infiltration. What are the advantages of using wet needle? Why not use the needle without the saline? We are calling it wet needle because of the priming we did for the needle with saline. What are the advantages of this technique? If infiltration occurs with saline, the saline is less harmful than blood to the fistula and surrounding tissue, and it is easily absorbed, by the way. And also, the use of this wet needle with saline eliminates the potential for blood to leak or spill from the needle when the caps are opened, so it is more safe for the patient and the working staff. Also, in the first cannulation, it's better to use needle with the back eye. Needle with the back eye optimizes flow from the axis. This is the back eye. And if there is evidence that it may minimize the need for needle rotation. What is needle rotation? I will talk about it in the next slides. Regarding needle size selection, I will mention again in this lecture that we have different sizes for different needles. It's better to use the small size, the smallest size of the needles, which is 17. This is the red needle, and it can accept blood flow up to 300. So use the smallest size in the first cannulation, and later on we can change the size according to the response of the fistula, as we will mention later. So you have to the smallest. 17 is the smallest gauge needle. I will show you this table in details later. Finally, the use of ultrasound. This is recommended by Kiduki 2019 and European Renal Practice Guidelines 2019, that it is reasonable to use ultrasound for proper needle placement in fistula, and it should be performed by trained operators to prevent cannulation complications. And the use of ultrasound for AVF cannulation can be done for first use cannulation and also for regular cannulation, as I will mention now. So let's go through general instructions for regular cannulation. We now talked about first cannulation. What about regular cannulation in the coming hemodialysis sessions? We have 12 points to consider in regular cannulation of AV fistula. The first, you have to educate your patient on washing the access arm with antiseptic, example by water and soap, to clean the skin before every cannulation. Also, skin preparation should be done by aseptic technique, and this is very logical. In some patients, anesthesia with topical cream can be used, however, it is rarely needed. In patients with high pain sensitivity, you can use topical cream with anesthetic effect, so the patient cannot feel the painful stimulation of the needle. For sure, use of tourniquet helps to enlarge the veins and facilitates AVF cannulation. Again and again, the use of ultrasound is reasonable in the AV axis of selected patients to prevent cannulation complications. Regarding needle size, okay, first, before I am going through this table, please correct in your table in the book, in the blue needle, it is written in some in the book from 150 to 450. No, it is from 350 to 450. Correct it as I am showing you here. If the version of the book you are having is corrected already, so it is okay. We have different needles with different wing color. The red needle is the smallest. The green size is 16. The blue 15. The white is 14. The white is the largest needle, and each of these needles has a maximum blood flow rate. For sure, the smallest has the lowest blood flow rate, and so on. As we mentioned in the first cannulation, we start by the red needle. Then, according to the response of the patient, in the subsequent hemodialysis, larger needles can be used, targeting a high blood flow rate. We are targeting blood flow rate to be more than 350 or about 350. Regarding arterial and venous needle positioning, this is a very important. Let's imagine this is the fistula, this is the arterial segment, and this is the venous segment. Regarding the arterial needle, which is called arterial inlet or upstream needle, it is usually cannulated pointing in a downstream direction. Downstream direction, I mean that it is directed toward the heart. This is the most popular cannulation direction, but actually it can be used also pointing upstream. It can be used pointing in this direction, but pointing downstream is more popular. Why? I will tell you. If you cannulate the arterial needle in downstream direction, you will make a flap like this. This flap left behind the needle, when the needle is withdrawn, this flap tends to close more with the natural flow of the vein. But if you cannulated the needle in the upstream direction, the flap will be in the direction of blood flow, which will make it open for longer time. So this helps in more hemostasis than this. Important point that the arterial needle should be away from the anastomotic site. This is the anastomotic site, about 3 cm or more. This important to protect the anastomotic site from cannulation injury. Then the venous needle, which is called the outlet or downstream needle, is always inserted pointing downstream, directed toward the heart, always in this direction. And the distance between the arterial needle and the venous needle should be always between 5 to 6 centimeters. So these are the directions of the cannulation and the distances that should be done between the anastomotic site and the arterial needle, and between the arterial needle and the venous needle. Okay. The next point in regular cannulation is needle insertion angle. As it was mentioned by Kiduki 2006 regarding the fistula, it should be inserted and the bevel should be down, and it should be inserted at angle of 25 degrees centigrade with the bevel up. Then a needle axis rotation should be done. That was what was I mentioned when I was talking about the back eye needle. Why needle axis rotation is important? Let's imagine this is the venous segment and you inserted the needle with the bevel up. This bevel up may cause trauma to the back wall of the vein. So you have to rotate the needle to make the bevel down, to make it in this shape, to make the bevel up down. So this will help to prevent the needle from injuring the back wall of the vessel. Regarding cannulation techniques, and this is very, very, very important, we have two cannulation techniques. The first technique is the rope ladder technique. It's also called the rotational cannulation approach. And the second technique is called the buttonhole technique. I will start by the first technique, which is the rope ladder technique. It is called rope ladder in relation to the rope ladder in this picture. The rope ladder technique, this approach means using the entire length of the axis for cannulation without localizing the needle in two only fixed area. For example, if you put the arterial needle in this point and the venous needle in this point in this dialysis session, in the next session you have to cannulate another site, and the next another site, and the next another site. The same if you are climbing this rope ladder. This is very important to help in the prevention of aneurysm and pseudoaneurysm that I will mention later. Because cannulation of the same site every time by sharp needle will make the wall of the vessel very weak, and this will lead to the development of aneurysm in the fistula. The second technique is the buttonhole technique. In the buttonhole technique, you will try to make a buttonhole like this, where you can cannulate your button, which I mean here by button the needle itself. To create a buttonhole technique, at first you have to use sharp needle. In this sharp needle, each time you have to puncture the fistula in the exact same point, at the same angle, at the same needle tract, and at the same penetration depth every time. This will help in the creation of this tract. After the creation of this tract by the sharp needle, you can use now the blunt needle, this blunt needle, to prevent severe injury to the wall of the vessel and prevent the formation of the aneurysm. So what are the disadvantages of this buttonhole technique? The first, it increases the risk of infection. It carries a high risk of infection. That's why it is important to follow strict antiseptic measures while using this technique. The second is the degree of its success is highly technique dependent. As I mentioned, that you have to create the tract, you should to cannulate every time at the same angle, same depth, and so on. So it is very difficult technique. So when should we use this technique? First, we have to use this technique in patients with AV fistula who have only a short or small segment for cannulation. the venous segment for cannulation is very short. We mentioned before that the venous segment of cannulation should be more than 6 centimeters. But in some patients, if there is aneurysm in the segment, if there is a skin infection, if there is a skin lesion that prevent to make a raw bladder technique and the area for cannulation is small, you can use this technique. Again, as I mentioned, if there is enlarging or large aneurysm that prevent expansion, that you need to prevent its expansion, it's better to use this technique in the segment of the fistula without aneurysm. Finally, if there is failure of raw bladder technique, you can use this technique, and the failure of raw bladder technique is usually very common in patients on home hemodialysis, in which some of the patients cannulate themselves. So in these patients, you can use buttonhole technique, but it's important to use excellent hygiene and aseptic measures.
So now we have two methods of cannulation: the raw bladder technique, as this photo and this image, and the buttonhole, where you make a subcutaneous tunnel. You will find only one cannulation site. But what may be common in practice, but it is not right to be used, is the area cannulation, that you are cannulating same area or same region multiple times near each other. In this situation, you are cannulating 1 centi or 2 centimeters of the vein different times following each other, and this will make weakness of the wall of the vein with the possibility of the formation of aneurysm and pseudoaneurysm. So cannulation of the same area different times is considered as a faulty technique. We have to use the raw bladder technique or buttonhole technique, as we mentioned, according to the available indications.
Regarding the point number 11 in the general instructions of regular cannulation is prevention of infiltration. Infiltration is a very annoying complication, and I will talk about how to manage infiltration in the next lecture if infiltration happened. But it is important to prevent infiltration to happen. How to prevent the infiltration? First, avoid lifting the needle up after insertion. Second, you have to use proper tapping to fix the needle to prevent infiltration. The third, proper needle removal is important to prevent post-dialysis infiltration. This is done that before the needle removal, you have to apply the dressing over the needle site, but don't apply pressure yet. When the needle is in the vein, don't apply pressure by the dressing. Then carefully you have to remove the needle at the same angle of insertion. Then once the needle is removed, you have to apply pressure by the dressing. But while you are making a pressure, be sure that you are occluding the tract of the needle only, not occluding the fistula itself. Then you have to monitor closely for any signs of infiltration. If infiltration happened, rapid response is required, and I will talk about how to respond to infiltration later in the coming lecture when we will talk about complications of AV fistula. The last point in regular cannulation of AV fistula is hemostasis post-dialysis. After removing the needle, you have to apply pressure by 1 or 2 fingers, and again be sure that the pressure is not too strong which may obstruct the fistula itself. You have to obstruct only the tract of the needle. The second point, the pressure that you should do must be maintained for a minimum of 10 minutes before any assessment of bleeding at the puncture site. If the bleeding is prolonged after dialysis, we mentioned that before in lecture 7 when we were discussing chapter 7 of anticoagulation during hemodialysis. If there is prolonged bleeding after
hemodialysis, you have to reevaluate the dose of heparin, check the vascular access for possibility of outflow stenosis, and I will talk about outflow stenosis in the coming lecture, and also at the end of this lecture. Evaluate the insertion technique and check if your patient is on oral anticoagulants. Finally, it is not advisable to apply the adhesive bandages until complete hemostasis has been done. And it is important because we saw before some patients who had their adhesive bandages, and when they go home, they found the bleeding from the fistula site. So be sure of complete hemostasis before sending your patient to home. We finished now talking and discussion about upper extremity AV fistula. Now we will go through upper extremity AV graft. The first point to mention what is the main indication of AV graft and when should AV graft be created. AV graft is indicated whenever AV fistula cannot be created due to poor vessels, non-distendable vessels, narrow vessels, or unhealthy vessels. Regarding when to create AV fistula, regarding when to create AV graft, actually AV graft doesn't require a long maturation time as the case in AV fistula. So it is enough to create the fistula if hemodialysis is expected in patient to be started within 2 to 4 weeks only. AV graft needs only 2 to 4 weeks to be maturated. Only 2 to 4 weeks to mature. Regarding AV graft pre-operative evaluation, we mentioned before AVF pre-operative evaluation. What about AV graft pre-operative maturation? Actually, it is similar to the AVF pre-operative maturation. Regarding AV graft material, what is the material from which AV graft is formed? The most commonly used material is the PTFE material. There are biological grafts, but actually the aneurysm in these grafts is very common than the PTFE grafts. There are other grafts than PTF grafts, but actually they showed no extra benefit over the most commonly used PTFE graft. Regarding the possible locations of AV graft, a lot of possible locations are available for AV graft. Many locations. I will mention one of the most commonly used. The first is loop arm brachial artery to cephalic vein or brachial artery to basilic vein loop graft. This is brachial artery to basilic vein loop graft in the arm. Then the next is straight forearm radial artery to cephalic. This is the straight forearm radial to cephalic. Then loop upper arm axillary artery to axillary vein. This is the one. Then straight arm brachial to axillary vein. This is the one. So a lot of other locations are available, but this may be the most common used. The next point is regarding the perioperative prophylactic antibiotics. We discussed before the perioperative prophylactic antibiotics in the fistula, and we mentioned that antibiotics are indicated in complicated fistulas or complex fistulas. Regarding AV graft, it is recommended by European renal practice guidelines that giving perioperative antibiotic prophylaxis for AV grafts insertion or AV grafts insertion, because the risk of infection is higher in AV graft than AV fistula, and we will mention this later in the complications in next lecture, inshallah. Regarding post-operative instructions in the graft are the same as we mentioned in the fistula, except that there is no any rule for exercise at all for AV graft maturation. Regarding first cannulation of the AV graft, we discussed before AVF first cannulation. Regarding the AV graft first cannulation, it is the same as AV fistula, but
there are some points that are unique for the AV graft. First, don't try to cannulate the graft before 2 weeks, because we mentioned that maturation of the graft occurs within 2 to 4 weeks. And maturation of the graft is indicated by the following. First, resolution of edema and erythema due to the surgery itself, because edema and erythema will make the graft difficult to be assessed and not palpable. So the resolution of edema and erythema after 2 to 4 weeks makes the graft easily and freely palpable. Second, the duration of 2 to 4 weeks helps to develop adhesions between the graft and the subcutaneous tunnel in which the graft is implanted. And this is very important to prevent hematoma, because early cannulation of the graft before these adhesions are developed will make hematoma in this tunnel and will cause compression of the graft and the graft loss. The third, within 2 to 4 weeks, the flow of the forearm graft or any graft will reach its maximum. For example, in the AV graft, the flow may reach 1000 ml per minute. Premature cannulation of the graft will lead to extravasation of the blood into the tunnel before adhesions developed, which will cause compression of the graft and graft loss. Regarding general instructions of regular cannulation of AV graft, they are the same as general instruction for regular AVF cannulation, but with some unique points for AV graft. What are the unique points or differences in the AV graft cannulation than AVF cannulation? First, there is no rule for the use of tourniquet in AV graft. Second, the needle insertion angle. In the AV fistula, we mentioned that the needle insertion angle should be 25 degrees. Here it should be 45 degrees with the bevel up. The buttonhole technique that we mentioned with the AVF shouldn't be used with the AV graft, because the buttonhole technique itself carries risk of infection, and also the risk of infection is high in the AV graft, as we will mention in the next lecture. So it's better to avoid the buttonhole technique in patients with BTFE grafts. However, it was mentioned in some references that the use of buttonhole technique can be used in other materials of AV graft, but actually other materials are not commonly used. So it's better to avoid the buttonhole with the AV graft. Regarding improving patency of AV graft, the Keduki Vascular Access Guidelines 2019 mentioned that combination of dipyridamole and aspirin twice daily can help to improve AV graft primary patency after careful consideration of potential individual patient benefits, risk, and circumstances. Regarding the use of oral fish oil to improve AV graft patency, actually there is no evidence that it improves the patency, but it only reduces the patient morbidity. Patients with AVF, the use of oral fish oil in patients with AV graft, oral fish oil reduces patient morbidity, but there is inadequate evidence that it will prolong AV graft cumulative patency. Now, which to use, AV fistula or AV graft? For long years ago, we used the slogan fistula first. And the fistula, we said before that the fistula should be created for every end-stage kidney disease patient. But actually, this slogan and concept has been changed by the Keduki 2019 updates from the fistula first to patient first, or in other words, the right access in the right patient at the right time, according to careful consideration of patients in the stage kidney disease life plan. As I will mention, and I will show you now, for example, I will mention a small example before going through details. If you have a patient who is with terminal malignancy, metastasis, and life expectancy less than 1 year, and the patient now, you diagnosed him as end-stage kidney disease, should you make AV fistula in this patient? For sure, the answer is no. Maybe in this patient, the use of central venous catheter is better. So, not all patients are fit for fistula. That's why the concept changed from fistula first to patient first, or in other terms, the right axis in the right patient at the right time. And I advise you to open the Kiduki Vascular Access Guidelines 2019 updates, because they put different or an example of different end-stage kidney disease life plan and case scenarios, real case scenarios, and how to choose vascular access in these different case scenarios. You will find these algorithms and case scenarios, and also they put some algorithms, very nice algorithms. You will find them in page S36 to page S39. These are the algorithms. And regarding the case scenarios, you will find them in a table in page S44 in the Kiduki Vascular Access Guidelines. So the Kiduki mentioned 4 paths, path A, B, C, and D, according to the end-stage life plan of the patient. I will not go in details. I mean, I will not read all the recommendations, but I will mention the idea. For example, here they mention that if there is anticipated long duration of hemodialysis. Long duration means that the patient will need dialysis more than 1 year. You can use forearm AV fistula, forearm loop AV graft, and so on. Then path B, if the anticipated duration of hemodialysis is less than 1 year, so these are the options. Third, if the patient urgently starts hemodialysis without prior sufficient time to plan for AV access, and the duration on hemodialysis is less than 1 year, these are the options. And finally, if the patient also started hemodialysis urgently without enough time to create the AV access, and the anticipated time is more 1 year on hemodialysis, these are the options. I will not read the options, it is very easy to read, but I want to mention some points. In these options, you will find that they put AV fistula, AV graft, and a central venous catheter in some situations. Whenever there is the option to use AV fistula, AV graft, or catheter, always the preferred to be used is the AV access and AV graft over the catheter. Okay? Again, whenever there is a possibility of AV graft, AV fistula, and the catheter, it's better to use AV fistula and AV graft, as mentioned by the Kiduki, than the catheter, because catheter carries more risk of infection. And whenever there is the availability to use AV fistula and the graft, and the opportunity of the both are the same, it's better to use AV fistula than AV graft, because also AV graft carries more risk of complication and infection and for AV fistula than AV fistula. So the first should be AV fistula, the second should be AV graft, the third should be central venous catheter, whenever they are on the same scale. Okay? The next point is when to use lower extremity AV fistula or AV graft or hero graft. First, what is hero graft? Hero is abbreviation for hemodialysis reliable outflow. It is a vascular access that is a hybrid, a combination of both catheter and PTFE graft. Okay, so it is a part of it is a catheter, and the part of it is a graft. So when to use lower extremity AVF or AV graft or this hero graft? You have to use it when all AV access options in the upper extremity have been exhausted, and the patient's end-stage kidney disease life plan includes a long duration more than 1 year on hemodialysis. But you have to put in mind that risk of infection from lower extremity AVF or AV graft is very high, with a poor outcome for the patients. Now, for the last point in our lecture, which is clinical monitoring. physical examination of AV fistula and AV graft. Before going through different steps of examination, it's important to mention that one of the most important advantages of clinical examination of fistula and graft is that it is non-invasive and cost-effective, and it can detect and localize stenotic lesions in most patients with AV access. That's why Kiduki considered that it is reasonable for all nephrologists and health practitioners in hemodialysis units to be well trained on physical examination of AV access. And the AV access clinical monitoring and physical examination should be done before every cannulation to detect any clinical indicators of flow dysfunction or any potential complication. We have 4 items for examination. The first is inspection, then palpation, auscultation, and finally some specific tests for AV access. Regarding inspection, we have to cover 7 points. First is the vascular access scar site. According to the scar site, you can predict the type or the location of anastomosis. For sure, the vascular surgeon informed you about the site of the anastomosis, but also the scar site can inform you about the site of the anastomosis. For example, in the radiocephalic fistula, you'll find the scar here at the wrist. For brachiocephalic fistula, you'll find this transverse scar, and in the transposed brachiobasalic fistula, you'll find the scar in the inside of the arm as this. Then you have to search for any signs of inflammation and infection. For example, if there is redness, hotness, if there is drainage, induration, pus, if there is a skin rash, maybe due to allergic reaction, secondary to use of betadine or antibiotic cream or any other locally administered material. And all of these signs of infection and inflammation can be associated with pain and or fever. Then you have search or inspect for any signs of infiltration or hematoma. Infiltration or hematoma can develop due to improper cannulation technique, and we mentioned how to avoid infiltration and the hematoma formation in our patients. Then you have to search for signs of hand ischemia, Steele syndrome. We will talk about Steele syndrome in details in the next lecture when we will talk about the complications of arteriovenous fistula and graft. But in short, Steele syndrome pathogenesis is that in normal population there is a perfusion of the hand by the normal circulation. When we do the AV fistula steals some of the blood from the systemic circulation. That blood supposed to go to the hand. So the fistula steals some of this blood, causing ischemia of the hand. In these patients, you might find blue hand, cold hands, pain and paresthesia, maybe skin ulcers in severe cases, and finally maybe dry gangrene, which lead to amputation. Then you have to search for aneurysm and pseudoaneurysm, and again we will talk about aneurysm and pseudoaneurysm in the coming lecture in details. But we have to define in our examination, is this aneurysm or pseudoaneurysm stable or not? To say that this is aneurysm or pseudoaneurysm is stable, the overlying skin must be intact without any changes in pigmentation. The fistula should show no evidence of outflow obstruction, and I will mention in this lecture, at the end of this lecture, how to detect that there is outflow obstruction in this fistula by using arm elevation test. And to say that this aneurysm is stable, its size should be stationary. But the opposite, what is the unstable aneurysm with impending rupture, and this should be considered as emergency, surgical emergency, and the access should be ligated, as I will mention in the coming lecture. The aneurysm is unstable if the overlying skin is thin and shiny with depigmentation and ulceration of the overlying skin, or if the aneurysm is rapidly enlarging in size, or if there is prolonged leaking after needle removal. The next point in inspection is to detect any signs of central stenosis, the central venous stenosis. As I mentioned before, we will talk about central venous stenosis in details in chapter 12, but in general, in central venous stenosis, you can find increased arm circumference at the site of central venous stenosis. You can find also edema of the face, neck, upper extremity, and breast. And for sure, you can find the collaterals, as these also collaterals on the chest and shoulders, different collaterals because of central venous stenosis. Finally, in inspection, you have to notify any scars on the chest wall or any evidence of previous surgery or central venous catheter insertion. Then we have to go through palpation. To palpate the axis, you have to palpate the AV axis pulse and thrill, and you have to compare the upper limb that contains the axis versus the non-axis extremity. Starting by palpation of the AV axis pulse and thrill. Before going this, I will have to put some rules with you. The arterial segment is called the inflow direction or segment of the fistula, and this is the outflow segment of the fistula. Okay, we palpate for the axis and the thrill. Regarding the pulse of the fistula, what is the normal pulse? What if there is outflow stenosis? What if there is inflow stenosis? The normal AV fistula pulse is soft and easily compressed by gentle pressure. If there is outflow stenosis, what is called by outflow stenosis? If there is a stenosis here, for example, the pulse will be hyperpulsatile and water hammer pulse. This before the fistula. Before the stenosis. The pulse will be exaggerated, hyperpulsatile and water hammer pulse. And this will go with the clinical history and scenario that there is prolonged bleeding after removal of the access needles, as we mentioned before. If there is prolonged bleeding after needle removal, you have to assess some points. One of them was to check for the evidence of outflow stenosis. In inflow stenosis, if there is a stenosis in the inflow segment, so the blood going through the fistula and the venous segment will be low, causing a hypopulsatile, feeble, flat pulse. And this goes with the clinical scenario, with the clinical scenario that there is an ability to aspirate blood from the fistula, that you need a high negative pressure to aspirate blood from the fistula because the inflow is weak. By the way, before I'm going through the AV axis thrill, regarding the stenosis, outflow and inflow, we will talk about them more and more in the next lecture when we are talking about the complications of AV axis. You have also to check AV axis thrill, an important point that you have to examine for the thrill from the site of anastomosis all the way to the chest wall. This is why because you have to know that AV fistula is not only about this point of anastomosis. AV fistula circulation is continued till the heart. So our examination for the AV fistula should be start from the fistula and should end at the heart. And that's why I will mention in AV fistula and AV graft examination, we have to examine the heart. Forgive me if I am saying AV fistula, AV fistula, AV fistula. If I say in examination AV fistula, I mean AV fistula and AV graft. But I used to say AV fistula because it is very common here in Egypt, then AV graft, and AV graft is not that common. Okay? So to examine for the thrill, you have to examine the thrill from the fistula up to the chest wall. Okay? Normally, the thrill of the fistula is continuous, systolic and diastolic. Except at the anastomosis itself, it is normally discontinuous. But normally all over the venous axis, it is a continuous systolic and diastolic. If there is outflow stenosis here, the thrill will be continuous. It is systolic and it is felt after the stenosis. In inflow stenosis, for sure, the inflow of the blood is low and the thrill will be weak or absent. Okay. The second point in palpation is to examine the axis versus the non-axis extremity for temperature, because if the axis arm is warm with swelling, this may indicate infection. If the axis arm is cold, it may indicate Steele syndrome. You have also to check grip strength, range of motion, and sensory function of the hand to detect Steele syndrome. Then we will go through auscultation. In auscultation, we will auscultate the AV axis itself, and we will auscultate the heart. Regarding AV axis auscultation, normally you will hear a bruit, and the bruit will be continuous, systolic and diastolic. If there is outflow stenosis here, the bruit will be very high pitched, loud, and it will be discontinuous, and it can be heard immediately here after the stenosis. Regarding inflow stenosis, the bruit is the same as thrill, but thrill is by palpation and bruit by auscultation. If there is inflow stenosis, the blood inflow into the fistula will be low, so the bruit will be low pitched and quiet. Regarding heart auscultation, we have to auscultate the heart of the patient for early detection of any newly formed murmurs, because this may indicate the development of infective endocarditis, which is may be common in our patients, because patients with fistula with the regular cannulation may precipitate infective endocarditis, especially under septic techniques. But it is important to mention that when you hear a murmur over the heart, the murmur may indicate a true murmur and infective endocarditis, or it may be this murmur only a transmission of the thrill sound. It may be a transmitted bruit. So how to differentiate if the murmur on the heart is a true murmur or it is just a transmitted sound from the fistula? This is done by just compression, gentle compression of the fistula to occlude the fistula. If this murmur disappeared after gentle compression of the fistula, so this murmur is just a transmitted sound from the AV axis, and if it is not disappeared, so it is a true murmur and should be investigated. Finally, we will go through AV axis specific tests. We have 3 tests that we should do for patients with AV axis. The first is arm elevation test. If this is the normal fistula and the vein is distended, as I show you here, you ask your patient to elevate his arm. Normally, the fistula, the venous segment and the fistula should collapse. This is its normal diameter, and this is after it collapsed. And if there is aneurysm, the aneurysm also should collapse. If the patient elevated his arm and there is no collapse of the fistula or of the aneurysm, if it is present, this indicates the presence of outflow stenosis. The second is augmentation test. In augmentation test, its importance is to assess the possibility of inflow stenosis. You have to place one of your fingers on the outflow segment here and press down to occlude the AV axis. Then feel the pulse by the other finger distally to the point of occlusion. Normally, there will be pulse augmentation and the thrill will disappear. There are other 2 abnormal options. The first, that when you occlude here, these fingers feels no thrill and no pulse augmentation. This means that there is inflow stenosis. As in inflow stenosis here, the inflow of blood is weak, so there is no here pulse augmentation or thrill. The second abnormal option, that when you occluded here, this finger felt thrill, normal thrill, but no pulse augmentation. This indicates the presence of accessory veins that drain the blood out of the fistula. And from this point, it is important when you find this option, you have to do what is called sequential occlusion test. Sequential occlusion test is important to detect the level of these accessory veins. We will talk in the next lecture more about accessory veins and these collaterals and their management, but in general, they are collaterals that are usually responsible for primary maturation failure of the fistula after the surgery. Immediately after the surgery, at 6 weeks, the fistula doesn't mature. One of the causes of failure of maturation of the fistula is the presence of these collateral veins, and actually they are diagnosed by fistulogram, but you can diagnose them clinically, as I am mentioning now. And they call that. They mention that, or they like to call the action of these collaterals as siphon off or siphon like, as they drain the blood from the fistula as the siphon or the WC. So to detect the level of these accessory veins, you have to make the sequential occlusion test. Its idea is very easy. By moving the occluding finger downward to the anastomosis site. If you're still feeling no augmentation and thrill in the other finger here, so you didn't occlude the accessory vein yet. If the occlusion, after the occlusion, you felt here no thrill and no pulse augmentation, so this hand just passed the site of the collaterals. So you can detect the level of collaterals by this sequential occlusion test, and you can send your patient for evaluation of these collaterals and for their ligation, as we will mention in the coming lecture. Finally, we finished this long lecture talking about arteriovenous fistula and graft basics, creation, use, and examination. See you in the next lecture talking about AV fistula and graft complications, diagnosing, and management, and thank you.